Okay, good morning again, everybody. So let us continue with chapter 11 on schizophrenia. Well, every mental disorder is incredibly interesting, but this one, I think not only is it interesting, but is just so complex. There's just so many things involved in terms of symptoms and problems and so on. And well, with that, let's get right to schizophrenia. Okay, and let me pull it up here. Alrighty. So we will be looking at the category of disorders, the schizophrenia spectrum disorders. Okay, I'm going to be spending the bulk of today's discussion on schizophrenia, all the symptoms, theories be regarding its etiology as well as some of their treatments. I'm not going to probably get into so much some of the other diagnoses in this category, such as schizoaffective disorder and delusional disorder. I think I'm going to leave that to you with your reading and your review of the PowerPoint. Okay. So with that, let me start off with another DSM bedside story, the story of Emilio. Alrighty. Now, Emilio is a 40-year-old man who looks 10 years younger. He is brought to the hospital, his 12th hospitalization, by his mother because she is afraid of him. He is dressed in a ragged overcoat, bedroom slippers, a baseball cap, and wears several medals around his neck. His affect ranges from anger at his mother, quote, she feeds me shit, what comes out of other people's rectums, close quotes, to a giggling, obsequious seductiveness toward the interviewer. His speech and manner have a childlike quality, and he walks with a mincing step and exaggerated hip movements. His mother reports that he stopped taking his medications about a month ago and has since begun to hear voices and to look and act more bizarrely. When asked what he has been doing, he says, quote, eating wires and lighting fires, close quotes. Okay. Let's see. His kind of a little clang association there, which we'll get into later. Eating wires and lighting fires. His spontaneous speech is often incoherent and marked by frequent rhyming and clang associations, speech in which sounds rather than meaningful relationships govern word choice. Emilio's first hospitalization occurred after he dropped out of school at age 16. Okay? And since that time, he has never been able to attend school or hold a job. He has been treated with neuroleptics during his hospitalizations, but doesn't continue to take medication when he leaves. So he quickly becomes disorganized again. He lives with his elderly mother, but sometimes disappears for several months at a time and is eventually picked up by the police as he wanders in the streets. There is no known history of drug or alcohol abuse, interestingly enough. Alrighty, so that's the case of Emilio. Yeah. And traditionally, Emilio certainly meets the criteria for schizophrenia. And in earlier versions of the DSM, he would have been described as a disorganized type. Okay, people still use that kind of parlance around um, to distinguish it from a paranoid type or undifferentiated type. Yeah, paranoid meaning that the predominant symptom is a paranoid delusion, and undifferentiated when they're neither disorganized nor primarily delusional, but it seems to be a mix of different schizophrenia symptoms. Okay, um, so with schizophrenia, yeah, as kind of touched on in the case of Emilio, yeah, where his symptoms started at age 16, it typically starts in late adolescence and young adulthood. Yeah, very common time for schizophrenia symptoms to first show up is in the first year of college. Yeah, and it could be a combination of things. One, certainly just lifespan, yeah, age, but it also may be brought on by the stressors of going to college, yeah, going to university. The other reason why it may seemingly come out at university is perhaps a lot of these symptoms may have occurred before, maybe in high school, but people maybe brushed off those symptoms as just, teenage weirdness, or the family just got used to it and developed a certain threshold for bizarre behavior from the family member. And it wasn't until the family member left the home and went to went to college and lived with other people that it was so abundantly clear that the individual was suffering from symptoms of schizophrenia. It usually comes about, um, it could come about either suddenly or gradually within a few weeks or months. Yeah. Very often it's the latter. Yeah. There'll be some initial symptoms, and then over the course of weeks or months, you see an increasing severity of those symptoms. But you can have a fairly immediate onset, like, within a few days of symptoms as well. I think more commonly you'll hear the latter, a gradual presentation and increase in severity of symptoms. Now, there are three general ways to, three general phases in which the symptoms come about. The first is the prodromal phase, yeah, and that's the initial presentation of symptoms and a period of slow but of gradual deterioration in functioning, yeah, in terms of work or social functioning. And then you usually have what's referred to as an acute episode. Yeah, an acute episode is where you have this intense presentation of symptoms. And in schizophrenia, it may be very intense delusions with uh, strong emotions and behaviors related to those delusions, like if they're paranoid, being intensely afraid and aggressive. Yeah, you may have what's presented, what uh, you may have symptoms referred to as frank psychotic symptoms. Yeah, and these are the kinds of symptoms which are blatantly, clearly bizarre, like hallucinations, delusion, and other bizarre behavior. Like in the case of Emilio, yeah, how he wore, I think, a bathrobe and medals around his neck, and so on. Okay. Now, with treatment, usually with treatment, uh, an acute phase can be reduced. But just generally speaking, the other phase referred to, that's also relevant to schizophrenia, is the residual phase. And the residual phase is, as the term suggests, a return to the prodromal phase. Yeah. And the absence of severe psychotic symptoms, but usually you have what's remaining, some cognitive, social, and emotional problems going on and deficits. Now, in terms of what happens, in terms of the prognosis for individuals diagnosed as suffering from schizophrenia, yeah, you can see the prognosis is kind of breaking down into rule forts. Okay, about a quarter, upon receiving medication and treatment, can completely recover. Alrighty, about another quarter will improve after treatment, and but and they'll still be relatively independent, but not completely recovering from the symptoms. Yeah, but still relatively independent. They may have their own apartment, have a, you know, be able to work, and so on. Another quarter will be improved, but still they will almost always require, probably for the rest of their lives, at least currently, extensive supportive treatment. Yeah. So these are the folks who maybe live in a halfway house, maybe live with a group of other people, maybe with family members who can, accommodate them. But we'll always need extensive support in terms of um, home living, and yeah, you probably won't have any kind of. Most of the folks who fall into this category aren't able to demonstrate independent living. They may be able to continue with some education, but they very well may have some employment on a part-time basis, and so on. Okay, another 15% will just not improve. Yeah, and will always require some degree of hospitalization. We still do have long-term psychiatric hospitalization, for those suffering from schizophrenia. Yeah, but in the year 2021, the number of people in long-term care, long-term hospital care, is much less due to significant reductions in federal funding. Yeah, which occurred around the 1960s and through the 70s, which was related to um, the healthcare social phenomenon of deinstitutionalization. Yeah. Um, which resulted in tens and thousands of people being, you know, deinstitutionalized, in other words, not being removed from long-term psychiatric facilities and then placed in other types of facilities like day hospitals, residential treatment homes, and so on. All right. Day hospitals usually refer to a situation. Let me take a step back. Day hospitals refer to a situation where somebody lives, let's say, in a halfway house or with their family or in a small group under supervision, but during the day participate in rehab activities, therapeutic activities, and so on. Yeah. Social skills development. That's what a day hospital is. Yeah. So they only arrive to the hospital during the day, and very often it's not even 5 days out of the week. It's like 3 days out of the week. Yeah, and regrettably, about 10%, um, face mortality, and mostly due to suicide. Yeah. Just as an aside, also those with schizophrenia, they very often don't. Their lifespan is often a little shorter than the average lifespan. Yeah, if the average lifespan being, at this point, I think we're at what is it? Males 74, women at 81, something like that. For those suffering from schizophrenia, their lifespan is usually several years um, earlier. And the reason why that's the case, you rarely run into people diagnosed with schizophrenia who get into their 70s and into their 80s. Part of the reason that's hypothesized is because of the really just uh, great amount of damage to the brain that is part and parcel of schizophrenia, and that when you have that much damage to the brain, which we'll talk about later, structurally, the kind of damage that can occur, um, that's driven by the disorder. Yeah, and I'm not talking about like damage from a car accident, but that's driven by the disorder. That kind of really serious damage to the brain, invariably is going to affect other functions like cardiovascular system and so on. Okay, in terms of the diagnoses, what are some of the well, in terms of being diagnosed, you have to first of all you have to have at least one of options one, two, or three. Okay, these are referred to as the criterion A. Uh, excuse me. These are referred to as the criterion A, 1 through 5 symptoms. And to be diagnosed with schizophrenia, you have to have at least one, two, or three. Hallmark symptoms include delusions, hallucinations, and disorganized speech. Okay. Um, and I think in the case of Emilio, kind of illustrated each of those. All right. We'll parse out a little further what each of those concepts mean, what's meant by delusion, hallucination, and so on. Okay. Gross. Now it has to be one. It has to be to be diagnosed. Yeah. You have to meet one, two, or three. Other criterion A symptoms include being grossly disorganized or catatonic behavior. Yeah. So like Emilio's odd walk with his hip gesticulation, or remaining completely still and silent. I'll get into catatonia as well, and what that and what's involved in that symptom. Okay, and another important distinction to make with schizophrenia is the concept of negative versus positive symptoms. Okay, now negative versus positive doesn't mean bad versus good. It means the absence or the presence of something. Yeah. So negative symptoms, we're talking about the absence of behaviors you normally would see. Yeah, such as a range of affect or emotional energy. Yeah. Now, what's very common negative symptoms are flat affect. Okay. So the absence of a range of emotional energy, expression. The other is alogia, right? The absence of speech, right? Either having difficulty finding words or hardly speaking to people. Yeah. The other one is avolition, which is really among, I mean, each of these symptoms are difficult in their own way. What makes avolition particularly sad is that it's related to that having volition or voluntary behavior, right? Like getting up from your chair to go to the dinner table, or getting up to attend to yourself, right? Get yourself ready in the morning so that you can step out and catch the bus. Here, when this symptom refers to the absence of that, the absence of that energy, that voluntary, um, you know, behavior, that level of agency where you come up, where you say, okay, I'm going to go there, and you walk over there. That seems to be absent in some individuals. Avolition. Positive and positive symptoms refer to the presence of things which are problematic, like hallucinations, delusions. Okay. Now, between the two, negative symptoms tend to be more stable across time for individuals, whereas positive symptoms are more unstable, and they're also more amenable to treatment, like medications, like in particular hallucinations, which we'll get to in a moment. Symptoms have to be present for at least 6 months, and you need at least 1 month of criterion A. Okay, has to also be related to social occupational, a decrease in social occupational functioning, or even if the person is doing swell at work, all right, they're a musician and they can attend gigs and stuff like that, and they have a group of friends, but if it's causing them distress, yeah, then that qualifies as well, in addition to the other symptom requirements. Okay. In terms of differential diagnosis, you want to differentiate what you may be seeing if you suspect schizophrenia from other psychotic disorders, mood or cognitive disorders, other kind of medical conditions. And what can also be kind of tricky is when someone presents peculiar ideas, yeah, like of a particularly of a political or religious nature. Yeah. What you want to discern is to what extent those political religious beliefs are shared by some community. Yeah. So if it's shared by some religious community or political faction, then it argues against that those peculiar ideas being a symptom of schizophrenia. However, to the extent that it's not shared by any community, it's probably more so something that's a function of schizophrenia. Alrighty then. Before talking about disturbed thought and content, first we're going to talk about problems in thinking. Yeah, in terms of its content, what's being said, what's being understood or believed. Yeah, and here we're referring. Let me just go. Or here we're talking about delusions, right? Which may include content, ideas, stories, which are not based on reality. Okay, for which there's little to no evidence to support. Alrighty. Now, with that, I have another DSM story, the story of Agent Johnson. So let us hear the story of Agent Johnson. Okay. A tall, well-groomed 30-year-old African-American man walked into the emergency room of a large urban hospital registered under the name Harry Backman and asked to be admitted to Ward 3 of the Psychiatric Division. He claimed that despite the fact that all of his identification cards bore the name Harry Backman, his real name was Johnson. Quote, and your first name? Close quote, asked the resident psychiatrist. Quote, we're not allowed to divulge our first names, he confided. Alrighty. He went on to explain that in fact he was Agent Johnson, an FBI agent on a mission to find Harry Backman, who had last been seen in Pittsburgh several years earlier. He claimed to have followed Harry from city to city, often posing as a patient in the psychiatric hospitals where Harry had been treated in order to obtain information about him. Interesting. Harry had a seizure disorder for which he took phenytoin, I think it's pronounced, phenytoin, primidone, and he had also taken trifluoroperazine in the past. Agent Johnson did not take any medications, communicating with his superiors at the FBI via high-frequency radio stashed in his bag. Something to make a note of. Agent Johnson had come to the hospital in order to be admitted to the very ward on which Harry Backman had been treated as a 10-year-old boy in order to seek clues about Harry's whereabouts. The patient confided his fear that the quote, real Harry was in fact dead, and that an imposter might be posing as Harry in order to collect his welfare checks. During the interview, it's a little paranoid kind of quality to it, yeah. During the interview, the patient was generally cooperative and engaging. His affect ranged from serious to jocular, And when his story was challenged, he became defensive and hostile. There was no evidence of disorganized speech, cognitive impairment, or hallucinations. Results of a physical examination, including a thorough neurological examination and all laboratory tests, were normal. A call to the shelter where Agent Johnson had lived confirmed that his name was Harry Backman, that he carried diagnoses of chronic schizophrenia and seizure disorder, and that he was maintained on trifluoroperazine, uh, phenytoin, and primidone. These medications were subsequently prescribed by the emergency room physician. In addition, a social worker at the shelter said that Harry had been wandering the streets in the past few days, frequently not returning to the shelter at night. She had not witnessed any seizures, and she did not know anything about Agent Johnson. On the following day, the patient had a generalized tonic clonic seizure lasting approximately 2 minutes, during which he hit his head on the floor. He was treated in the medical emergency room. All tests, including a computed tomography scan, were normal. After a brief period of post-ictal confusion, the patient woke up. He responded to the name Harry and acknowledged that he had a seizure. The confused resident scratched her head and said, quote, "But I thought Harry had a seizure disorder," close quote. Um, and open quotes, "I am Harry," said the patient with a smile. Quote, "I found him." Oof. Okay. So with that, that's the story of Agent Johnson. All righty. Now, the interesting thing about Agent Johnson, first of all, he's a great example of suffering from schizophrenia and suffering from a delusional disorder. Okay. Now, as a general matter, you have to be diagnosed as suffering from a delusion, yeah, that arises from schizophrenia. The belief system has to be bizarre in nature. All righty. Now, this one might be kind of tricky, might be kind of debatable, right? Because he believes he's an FBI agent and that Harry Backman is missing, which isn't so bizarre. All righty. But what helps support the bizarre quality is when he says he can pick up radio signals, right, with a device supposedly on his person. That kind of suggests, that makes the story more odd. Um, and certainly the odd behavior, right, with the big switch, saying who he is and that he had found him. So he's suffering from a delusion. Now, how would you? Now, there are different types of delusions. Okay, probably the most common is a paranoid delusion, right? The fear that someone is after you, like the CIA, the KGB, yeah, aliens, and so on. Another very common one are grandiose delusions or delusions of grandeur. Okay. Now, delusions of grandeur usually involve a belief that the person, there's something great or fantastic about them, like they are like, um, the true czar of Russia or something, or the next emperor of China. That they usually it's the belief involves they're having some kind of greatness or greatness being imparted on them. They have the cure for cancer, all that kind of stuff. Interesting enough, delusions of grandeur and paranoid delusions tend to go hand in hand. Yeah, kind of like Agent Johnson. I mean, it wasn't really that paranoid, but there was a paranoid flavor to it, you can say, right? Not like cooking flavor, but a sense to it, in that Harry Backman, who he truly was, had disappeared, right? Um, Under mysterious circumstances. So that has it's certainly a paranoid quality to it. And interesting enough, right? Harry Backman, the real Harry Backman, who thought he was Agent Johnson, has this. I think you can count it as not being like thinking you're the Tsar of Russia or the last emperor of China, but he believed he was an FBI agent on a mission. Okay. Other delusions include control delusions. Okay, the belief that an enemy or some foreign entity is controlling one's thoughts, feelings, or behavior. Okay, there are beliefs of thought withdrawal, that literally thoughts, beliefs, ideas, memories are being removed in some fashion. Okay, thought insertion, right, the complete opposite, that they're having ideas, memories, images that are being like somehow radioed in or or projected into their brain. Yeah, or thought broadcasting, the idea that their thoughts are being heard by others. Okay, very interesting kind of grouping of bizarre beliefs. We talked about persecution. Um, Reference refers to, it's kind of similar to grandiose. It's not grandiose. Grandiose obviously relates to you thinking you're great or wonderful and all that kind of good stuff. Here, reference has to do, it's similar in that it has to, because it's similar in that it deals with one believing that it's a focus on the self in terms of one's importance in a sense. So often misinterpreting sounds or other stimulus having special reference only to the person, right? So it has this kind of sense of there's something special about you, like the television is talking to you. Yeah. If you ever get to see the documentary Imagine, it's a documentary on John Lennon's life from birth to when he was assassinated. And there's this scene, I think it takes place about 1971, where homeless gentleman appears in his backyard and was hanging out there for about a week. And finally, John, called the guy over and said, "Hey, what are you doing here?" And the guy had told Lennon that he thought that Lennon was speaking to him through his music. I forget which songs he said. I think he may have thought I'm the Walrus. Yeah, was being that John was singing to him, the homeless man, and so that's why he had arrived. Yeah, classic idea of reference. You can have somatic delusions too. Yeah, beliefs that there's something wrong with your body, that there's creatures in your body, and so on, despite medical evidence indicating the contrary. And another type of delusion, which has garnered a lot of attention because uh, of these some of these cases involving celebrities, the erotomanic delusion. And erotomanic delusion is the delusion that somebody else is in love with you, or that you're meant to be. Yeah, it's a very powerful delusion. Yeah, I think David Letterman had a stalker who believed that Letterman was in love with her. He didn't know her and that they were destined to be. I think Madonna maybe had a stalker of that sort. A number of other celebrities have had too. Yeah. What's concerning about these delusions is that they're not all just positive and rosy, and they also involve individuals not necessarily staying away from their object of desire. Yeah. And in some instances, when people suffering delusions, when their intentions are blocked by reality, right? Either by the target, right? The target of their affection, telling them, "Hey, no, I don't know you, stay away." Getting a TRO out on the individual with the erotomanic delusion. It's one of those kinds of delusions that can flip very quickly from love and adoration to rage and hate and desire to kill. Alrighty. Now, thought disorder. Okay, first we talked about um, of the types of disturbances in thought and speech. We first looked at those based on content, yeah, belief systems or delusions. The next refers to thought disorder. Now, here we're talking about the nature of thought, yeah, and just as a general matter, yeah, let's get to one of the most common types of thought disorder, which is loose associations. Okay, now loose associations basically describe a phenomenon which kind of fits with the term. Um, Now, when you think about you're listening to me, yeah, and my describing these ideas, yeah, hopefully you're seeing because I'm being clear and also you're being clear. Uh, Odds are we both are being clear because there's a connection, yeah, and a fairly close connection between the ideas I'm expressing. Yeah, talk about schizophrenia, symptoms, types of um, thought problems. First, talking about delusions. Now, talking about thought disorder. Okay, loose associations refer to the breakdown in the connection between ideas, the logical breakdown, yeah, or the associations or connections between different ideas. Alrighty, we'll look at an example of what loose associations can sound like. Alrighty. Another form of thought disorder is what's referred to as derailment. Yeah, and that refers to when one shifts from one idea to another, starts talking about bakery and then talking about my home and something like that. Shifting to already like two, three different ideas just with no apparent reason. Alrighty. The other refers to tangential connections between ideas. Yeah, when there's like no relationship between, talking about a can of beans and, the space program and what's going to happen with that. It's like, wow, when you shift like boom, 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 what does talking about schizophrenia, can of beans, and the space program have to do? Little to no relationship. The other derailment, there was some connection, right? But it has to do more with the shifting. Yeah, so the train's going in a certain direction, gets derailed, which is a bad thing, and it's a big shift, right? But there was still some connection. It was still headed in one direction. You can kind of think of. Okay, whereas tangential is just wow, it's going all over the place. Incoherent thought disorder may also be characterized by complete incoherence, where there aren't even connections between the words, let alone sentences or ideas being expressed. Okay. Clang associations include oral, speech in which what's being uttered, yeah, are words that sound alike, yeah, that seem to rhyme, kind of like in the case of Emilio, yeah. Um, and what was that clang association when he was asked? Let me just bring that out again. Um, oh, when asked what he had been doing, he says, "quote eating wires and lighting fires." Okay. Now, that may sound poetic to some, and maybe there are moments of poetry, but when someone's just responding and the words just sound alike, but and it's not being effective, it's not allowing them to be effective communicators, you're dealing with clang associations. Neologisms is when people create words, yeah, unique words. Alrighty. Now, granted, every human being does that every now and then, right? And certainly someone learning a new language, right? But people, when they do that and they're confronted on it, they go, "Oh yeah, I meant to say," right? Whether you're learning a new language or you just kind of made a slip of the tongue there, right? But what would be an example of a neologism? Let me think of some. I'll tell you some Beatle ones. Although Ringo Starr did not suffer from schizophrenia, right? Um, uh, like for example, instead of saying the expression "only tomorrow knows," right? He told John, "Tomorrow never knows." Like that's an exact example of a neologism, right? Kind of a twist on a common expression. Hard day's night, right? They were leaving after rehearsal. Ringo was just he just want to say, "Wow, that was hard day's work we put in." You know, lads. And but instead of hard day's work, as you're walking out, he noticed, wow, it was really dark, and he goes, "Oh, hard day's night." Right? So kind of made this kind of unique expression. But Ringo wasn't suffering from schizophrenia because he knew he was making up something novel. It's when the individual says these words, but they're not aware of it. And when you bring it to their attention, they're gonna kind of look at you like, "What? I don't get you." Perseveration is a symptom, and it can manifest itself in different ways. The best way to just generally describe perseveration is when one repeats something. Yeah, either they might repeat a word. They might make certain sounds over and over. They might like write like and dotting the end of the sentence just go dot 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 dot. It's almost like it sounds like an awful metaphor, but it's almost like the brain is operating like a broken record. Yeah. Well, I'm talking to a generation, many of whom may not know how records functioned or how they didn't function. But if you can imagine a record on a record player and there's a bit of dust, sometimes the needle would jump and it would just repeat the same thing, right? And it's kind of like this is what's happening to the brain, where the person just kind of repeats an action or statement or sound over and over and over. Yeah. And finally, poverty of speech, yeah, which, as the term connotes, involves a situation where someone can't find words or hardly speaks. Yeah. So, with that, though, let's look at perceptual disturbances. And with that, we're just going to take a brief break. Okay, folks, thanks for your patience, and let's continue. All righty. So another big area. This is one of the criterion A three symptoms that you need to have. Um, includes perceptual disturbances, yeah, or hallucinations, another hallmark symptom of schizophrenia. Now, there are some types of hallucinations which are more common than others. Yeah, the ones that, if you're going to pursue a career in mental health care, you'll run into more commonly are auditory hallucinations. Yeah, hearing voices, usually voices saying negative things to the individual, derogatory things, insulting things. Yeah, rarely do you have someone report a hallucination and the hallucination is saying supportive things to them, or like, "Hey, nice shoes." Nothing like, it's rare. You now almost never hear something like that. Okay, it's usually sadly stuff that makes a person upset. Yeah, where the voice puts them down or tells them other people are putting them down. The particularly concerning auditory hallucination, which if you're a healthcare professional, you should really keep your ears peeled out for, are directive hallucinations. The voices are telling the person to like go kill somebody. Um, those are have been associated with violent behavior, raise the risk of violent behavior. All righty. Voices don't often say stuff like that. All right. But when they do, and someone's reporting that, saying that the voices are telling them to harm somebody, you got to take that real seriously. Okay. Common ones include tactile, like they feel like weird sensations under their skin, like they think there's bugs under their skin. Somatic, if they think there are things in their body, like snakes, in their intestines, something like that. I know that's awful sounding. Um, but that's a very good example of a somatic symptom. Less common are visual hallucinations, taste. You almost never hear someone tasting something that they haven't put in their mouths, or smell. Yeah. Smell, regrettably, when you do hear a smell, olfactory hallucinations, it tends to be bad stuff, like people smell feces um, all around them. Visual hallucinations, although it's in this category of less common, you will hear these. This is kind of in between less common and common. It almost falls into the common category. Um, but the other thing to keep in mind with visual hallucinations, yeah, they tend to be a kind of vague, unclear images. Yeah, many individuals, when reporting visual hallucinations, will report shadows and things of that sort. Yeah, they see a shadow of a tiger or a shadow of a person. It's not a very clear image. Often, it's described as kind of a more dreamlike image. Um, you know, uh, every now and then you hear people, like for example, the math genius in A Beautiful Mind. He described his visual hallucinations to be so crisp and clear that he couldn't tell the difference between of his visual hallucination and someone who was actually standing there. He would literally turn to his students and say, "Is that person there?" And then the student would say, "No." And then he would know he's having a visual hallucination. Sometimes you hear of those very crisp and clear visual hallucinations, but they tend to be particularly rare. Other cognitive, I think the sense you're getting with schizophrenia is that, well, first I want to make it clear, not everybody has all of these symptoms. Yeah. But it's not unusual for someone to have one or two symptoms in each of these categories. Yeah, and that's what makes schizophrenia such a awful disorder to be suffering from. Yeah, because it involves you know um, problems in almost every major area of functioning. Yeah, in terms of mood, right, affect, um, cognition, thinking, behavior, right, gross motor behavior, and so on, and just so many other aspects of what makes a person, that their sense of self, their ideas and beliefs, their sensory experiences. So it's like such a global breakdown of so many aspects of human functioning. Yeah, that which really makes it such an awful thing to experience and painful thing for someone to suffer through. Other cognitive problems, which certainly go are associated with schizophrenia. General intelligence tends to be impaired. In other words, what their previous prior to the onset of the symptoms, yeah, or morbidity, first presentation of symptoms, often intelligence, if they don't completely resolve, right? Like you're in that one quarter of people completely resolve in their symptoms. If you're in the other three quarters that, always have some impairment, usually IQ and some specific cognitive functions get impaired. Yeah. Some of the cognitive functions very commonly logic, reasoning, abstract reasoning is usually impaired. Executive functions, yeah, which is huge. Our ability to organize, plan, I think in terms of plan for the future and so on. Memory impairments can occur, particularly for short-term memory, which can make learning very difficult for anybody if they have impairments with short-term memory. Yeah, be that ability to hold information for a short period of time to determine, what you're going to do with it. Yeah, that's why if you read off a phone number to someone with schizophrenia and they don't have something to write the phone number down onto, they got to keep it in their memory for like a moment or two. I mean, that can be tricky for a lot of us, but certainly for someone with schizophrenia, that's going to be, very, it can be very difficult. Attention seems to be impaired, particularly the ability to filter out irrelevant stimuli. Okay, and this is very often associated with filtering out hallucinations. Yeah, from other things that they need to attend to, like listening to people they're conversing with. Yeah, which often leads some to have a high hypervigilance, which sometimes leads some to be hypervigilant to extraneous sounds. Yeah, um, voices, hearing sounds around the corner, and so on. Okay, other problems, maybe motor behaviors, posture and movement abnormalities, like in the case with Emilio, flat or inappropriate affect. Problems orientation by three, time, place, and person. Yeah. And usually when you have an impairment in either, your sense of time, where you are, and who you are, yeah, usually the degree of severity can be related to what goes first. Yeah. Is it an impairment in time and or an impairment in where they are, their sense of where they are, and or finally the worst kind of situation is if they don't even know who they are. Yeah, which tends to be more rare, but can happen. Yeah, like in the case of Agent Johnson, right? Was it Agent Johnson or um, whose real name was Harry Backman? Yeah. Um, so that's that you don't find that very often. Someone thinks they're Jesus Christ, something of that sort. Yeah, even many of those who suffer from schizophrenia, they may be off with time. You ask them what year it is. Instead of 2021, they'll say it's 2019. You say where they are, they'll say Maui instead of Oahu, something like that. Yeah, but ultimately they still know who they are. Right? But some individuals, it can get so bad, right? Their sense of time is really off. Where they are, they have no idea, and then finally they think there's someone else. Okay. Loss of volition, again, goes to that loss of voluntary behaviors of agency, right? That if you want to get a meal, you get up from your chair and you walk over to the lunch table. Yeah. Impaired insight is also very, very common. Yeah. Um, and insight refers to that ability to be consciously aware that you have a problem, like symptoms. Yeah. Um, and that too, that there are things you can do to resolve those symptoms. That's another level of insight. Yeah. And so knowing factually and then having the kind of insight that it's to your advantage, right? So you're motivated to uh, do, take treatment, take your medications to take care of your symptoms. So you have symptoms, there's something out there that can help. And three, that you know personally for yourself, there's a good reason to do so. The benefits outweigh the cost, so you participate in treatment. Yeah, and those who suffer from schizophrenia often have some impairment along those three lines of insight. Yeah, and in the past, it's often thought, and maybe for some, a function of using an old Freudian term, denial, right? Not wanting to see what your problem is. And certainly people who suffer from schizophrenia are not the only ones who suffer from denial of seeing problems in their relationships or in themselves. Yeah. But for those suffering from schizophrenia, it may not just simply be that kind. It may be, for some, just a resistance to seeing how badly impaired they are. Yeah. Who'd want to acknowledge that? That would be such an incredibly difficult thing to acknowledge. But you know, there's been actually some studies to indicate how there may be actually parts of the brain that may be certain structures that may be you know, damaged or malfunctioning, such that they can't become aware. They can't have that insight. Yeah, so it's not a choice. Okay, depression, mood disorder is fairly common among those who suffer from schizophrenia, and as mentioned before, more than 10%, about 10 or more than 10% end their lives through suicide. Here's a painting done by a gentleman who suffers from schizophrenia, the paranoid type. You can see all the eyes and being looked at, being constantly aware of or believing that one is constantly being looked at. Um, Here's another painting by someone who suffered from schizophrenia. You can see kind of a merging of a lot of different ideas and concepts into this kind of, you know, kind of frightening, grotesque kind of image. And when providing a narrative to this painting, the artist stated, "This is the Holy Ghost. Oh, the Holy Ghost arose from a quote miracle in the insole of the victim, ruthlessly sacrificed, disinherited and declared dead by the secret, violent poisoning and brain crushing of assassins possessed by Satan and mentally disturbed." What? What is that you're saying? You know, this classic like line of ideas, of loose ideas kind of thrown together or attempted to be thrown together. Yeah, classic example of a loose association, thought disorder. There's another not painting, but drawing, right, with kind of you know, narrative kind of interwoven, right? So we see these figures and with odd looking hands, and then, you know, right, the text kind of written but in a really disorganized manner, right? Now obviously not left to right, but up and down, left and right, and so on. Here's another painting by someone who had paranoid delusions that there were monsters beneath his hospital bed, and this is the monster he painted or imagined was beneath his bed. Alrighty. Now, here are photos of individuals that illustrate some phenomena touched on earlier. On the right, we have a person just kind of giggling, kind of maniacally to themselves. Um, and, you know, sometimes you'll see this in individuals, right? That lack of control of emotions and inappropriate affect. Someone might be doing that like at a funeral or in the middle of temple or church or mosque. On the left is an illustration of someone who may be suffering from catatonia. Okay? Now, when someone is catatonic, as you're probably well familiar, it refers to a circumstance. It refers to a circumstance where they stay frozen in a body position and don't say anything for long periods of time. You know, when I was working in a forensic psychiatric facility back in New York, you know, we had a patient who did that. He would, I can't even recreate what he did, but he would sit in his chair and he would lean over, literally with his head between his knees, and he would hold that position for hours and not talk to anybody. You know? And in terms of the A volition, when it came to lunch, you know, the staff, and I gave them a lot of credit. They were incredibly patient. You know, just had to just patiently and quietly and gently try to encourage the patient to get up from his chair and walk towards the table. You know, I think he was such a sad looking case. I mean, first of all, we had good staff, but I think also because he was such a sad case, just people just felt so bad for this guy. So similarly, you know, we see an illustration of someone here is probably catatonic, leaning against the wall in an odd body position. And what's a towel on the head about? Well, we don't know. Interesting enough, when those who are catatonic, yeah, get the right combination of medications or the right dosage of a correct medication, and if their catatonia kind of resolves, yeah, um, and the patient is able to speak, you know, and about what they're thinking or what they're believing. Yeah. It's not uncommon that patients often describe delusions related to the catatonic body position. So, for example, I'm just making this up, but this person here, when well medicated, might later, yeah, when they're talk about how they leaned against the wall, for example, to keep out hell, the doors of hell from opening, right? And the towel was to keep out radio signals from Satan. That's an example, yeah, of how the catatonic behavior may actually be related to a belief system that the catatonic patient is holding on to. Here's another example of how catatonia may look. Someone might just stand there for hours with their hand, one hand down, pointing downwards, the other one up, with the fingers kind of curved that way. Now, what are the causes of schizophrenia? Yeah. Um, well, over the decades, this is what the research seems to show. Okay? It's clearly a genetically based disorder. Alrighty. It's not something that's caused by bad parenting. Alrighty. Now, are there environmental factors that can have a play? Certainly. We'll get into that in a moment. Okay. But there is certainly a genetic basis to schizophrenia. Twin research supports this. Among monozygotic twins, the concordance rate is up to 48%. Okay. But keep in mind, that's kind of a half full, half empty kind of deal. Yeah. Interesting enough, not all monozygotic twins, if one is suffering from schizophrenia, at least about 52% of the time, the other isn't. Okay? Which doesn't mean there's not a genetic component. Yeah. There is a genetic component. But for some reason in the other twin, yeah, those genes were triggered. Yeah. And what can trigger the genes? Yeah. Well, just think of like a heart condition, right? Some people in some families, they have a genetic predisposition for cancer, certain types of cancer, for heart attack. And then there's certain external factors that can trigger, right? The DNA, right, to do its thing. And what that trigger is, we'll touch on in just a moment. Among dizygotic twins, twins that are not identical but are born at the same time, concordance rate is much lower, but still, higher than the average, because the prevalence of schizophrenia in the general population is about 1%. Okay, and among dizygotic twins, right, if one twin is suffering from schizophrenia, there's about 17% likelihood that the other will as well. Okay. Adoption research also supports a genetic contribution, and again, other family studies. Yeah, usually the closer the degree of family relationship, the higher the probability of suffering from schizophrenia. There's a 1% chance in the general population. If you have an uncle or aunt who suffers from schizophrenia, there's a 2% chance you will. Let's see, if your sibling, right, non-twin sibling has schizophrenia, there's a 9% chance you will. If your parents suffer from schizophrenia, there's a 6% chance you will, and so on. Yeah, so the greater the degree of family relation, usually the increased risk or probability that if that family member suffers from schizophrenia, that you would as well. There are also neuroanatomical factors at play as well, and problems. Yeah, for example, what's found among many individuals suffering from schizophrenia are enlarged ventricles. Okay, in the brain. Now the ventricles refer to. Well, let me go to the picture in front. Right, this area right here that goes from the back of the brain. Right, this is a cutaway of the brain. Right, so going from the back to the front are these ventricles filled with fluid. Alrighty. Among those with schizophrenia, you can see it's enlarged significantly, right? So you can see the huge difference between the normal and the schizophrenic brain. All right. Now, how it contributes to schizophrenia probably has more to do not with the ventricles per se, but with the loss of brain tissue that goes along with the increased ventricles. And this loss of brain tissue will involve loss of tissue in the frontal lobes, temporal lobes, amygdala, and hippocampus. Yeah, so frontal lobes associated with executive functioning, temporal lobes associated with auditory organization and reasoning, the amygdala associated with emotional regulation, and the hippocampus involved in memory consolidation. Yeah, so all those areas can be affected by enlarged ventricles. Okay. Now, when we're talking about neuroanatomical damage or structural anomalies, so many studies show that those who suffer from schizophrenia suffer from that more than, and I shouldn't have used the term schizophrenic. I don't like the term schizophrenic, and I apologize. I just used that term a moment ago. Yeah, don't like referring to someone suffering from a disorder, disease as that disease, right? Don't refer to someone with cancer as a canceric, right? So I try to avoid calling someone who suffers from schizophrenia schizophrenic, although it's very commonly used. I like to avoid using that. But there, getting back to away from my guilt and then back to the research. Um, so with those suffering from schizophrenia, a lot of these neuroanatomical anomalies may occur with those suffering from schizophrenia. But here's the big but: not all the time, right? So, for example, with the enlarged ventricles, many a time, okay, those who suffer from schizophrenia will demonstrate the same enlarged ventricles, okay. But there are also those who with schizophrenia where you don't see that same kind of brain scan. Other neuroanatomical anomalies, there's a lower level of neuroactivity in the prefrontal cortex, okay, goes to the executive functions, and abnormalities in brain circuitry connecting the prefrontal cortex and lower brain level structures, yeah, that go to, right, the limbic system, emotional regulation, and also other lower brain structures related to motor functions, right? So that's why we might see this complex um, presentation of problems with complex thinking, emotions, relating with people, and even with just standing and walking. Okay. Now, other data in terms of suggesting causes find complications that may occur during the second trimester in pregnancies. For example, the exposure to certain viral infections during the second trimester. There's been, a good um, number of studies that have supported that as being a possible contributing factor. Yeah, as well as maternal stress, yeah, which increase the production of stress hormones and has a negative, which will have a negative influence on fetal brain development. Neurochemically, what's probably going on, one of the chemical neurotransmitters most implicated in schizophrenia is dopamine. Yeah, and we see a higher presence or production of dopamine in those suffering from schizophrenia. Antipsychotic medications generally work by blocking dopamine receptors, and drugs that increase dopamine, like LSD, right, um, produce symptoms which are psychotic like hallucinations, visual, auditory, and so on. With that, let me pause here for a moment. Okay, thank you. And let us continue. Psychological factors that can contribute to schizophrenia. Uh, there's some data to show that those who patients with schizophrenia are in families where the family members, all the family members, demonstrate problems in communication. Yeah, what's been referred to as communication deviance, uh, showing a pattern of vague, disruptive, of fragmented communication, which some posit may contribute to the poor decrements in logic or thought disorder in the schizophrenia patient. Express emotion has also been seen as a construct of interest in these families, in that of those individuals in these patients in with schizophrenia, that their families demonstrate more hostile, unsupportive communication. But what's not clear, yeah, is what came first. Was it the family pattern, and did that contribute to the individual with schizophrenia and their symptoms, or was it the other way around? Was it someone with schizophrenia leading to stress in the family, which may contribute to hostile and supportive communications, or people coming up, family members coming up with a way of communicating that mirrors what the patient with schizophrenia is doing? It's not clear. It could be bidirectional. There's evidence to show that there's a higher prevalence of schizophrenia lows in lower socioeconomic groups. One hypothesis, though, is that it may not just be occurring more, but it may be a function of in those if in lower SAS groups, but that those in middle and higher SAS groups, yeah, when they are struggling with schizophrenia, end up are going into lower SES groups because they're not able to function, continue with education, have difficulty getting work. So then they start joining the pool of lower SES individuals. Okay. It may also have to do with access to treatment. Yeah, that those from middle upper class backgrounds can get the treatment ahead of time. Yeah, both psychological and biological, which decreases or improves the prognosis for schizophrenia, decreases the presence of symptoms, and so on. And finally, it's also, I think, reasonably postulated that those in lower SES groups tend to have higher stressors, obviously financially, perhaps in certain neighborhoods in terms of crime and violence and so on. Yeah. And finally, there's the diathesis stress model, alrighty, which suggests that the onset of schizophrenia is a function of having a genetic predisposition that is subjected to some stressor. Okay. And here, stress, we're not talking about, oh, being afraid that you're going to have a 10-question quiz next week, but really severe stressors like being exposed to war or some kind of physical sexual trauma and so on, or head injury and so forth. Yeah. And you can kind of um, analogize this to a heart condition. Yeah. If you may be genetically predisposed to have a heart attack, right? Because you have a whole bunch of family members, you had a parent who had a heart attack, a whole bunch of other family members had a heart attack. But if your life is relatively stress free, you exercise, you maintain a good diet, you don't smoke, you only drink on occasion, right? You decrease the risk of having a heart attack. You may never have a heart attack. Same thing with those with schizophrenia. They may be genetically predisposed to have schizophrenia, but right, if they experience no trauma, their lives are relatively stress free, they don't do drugs, um, um, you know, let's see, they're relatively healthy in terms of diet and exercise, yeah, they decrease the likelihood of having schizophrenia. And that's why the family data we saw before, particularly with the monozygotic twin data, that might explain in large part why you don't see schizophrenia in the identical twin, right? They have the same genes, but those genes just very well may not be triggered by some stressor that the other twin may have experienced, yeah, including maybe exposure to prenatal stress hormones. Yeah. Even though the mother is experiencing stress and the hormones would have been, um, you know, going through the womb where both twins are identical twins, it's possible that one may be exposed to more of those stress hormones based on where the fetus was located in the womb than the other, right? Not that the other didn't experience any of those stress hormones, but it's possible that one of the two identical twins was exposed to more of the stress hormones than the other. And by the way, that's getting back to treatment. What's really important to keep in mind, and there's been growing body of data to evidence to support this, that the earlier you catch the onset of schizophrenia, same thing I think I said with mood disorders, and major depression. The earlier you can catch an episode, the first, see the prodromal phase before an acute episode, if you can prevent an acute episode from occurring, you really improve the prognosis for the individual. Yeah. But the more they have an acute episode that's not treated, and then another acute episode, and then another acute episode, yeah, you really increase the likelihood of more psychotic episodes and decrease the likelihood of a good prognosis. Yeah, the prognosis just starts getting worse. See? Same thing with untreated heart attacks. Yeah, you might, the more a heart attack is not treated or caught ahead of time, the greater the risk for another heart attack or a more severe heart attack. Some of the common treatments, the first go-to thing is biological, and by biological, primarily medications. Yeah, there are basically two groups: the phenothiazines and the atypical antipsychotics. The phenothiazines will include medications such as thorazine, stelazine, prolixin, and also besides the phenothiazines, another old one is Haldol. Okay. These are the ones that have been around since about the 50s, and they're effective in the sense that they can lower uh, hallucinations and also reduce affective instability. Okay? For all these antipsychotics, whether it's the phenothiazines, Haldol, or the atypical antipsychotics, these usually don't make much of a dent in delusions. Okay? Now, The individual may report the delusion less frequently, less intensely, and so on. But there's usually some subscription or still articulation of belief in the delusion. Yeah? What may be actually more affecting the presentation of the delusion is the decrease in affective instability. Yeah? So they're not intensely angry and enraged, not in constant terror, right? Or and even individuals with schizophrenia aren't usually in constant terror, but highly anxious. So you reduce anxiety and reduce the anger and the rage. They won't adhere to the delusions nearly as firmly or as staunchly. But that doesn't mean the delusion is gone. Yeah, and rarely do you hear situations of that sort. But in terms of auditory visual hallucinations, some individuals will report complete disappearance of hallucinations. Okay, thought disorder is the other thing that often is not, it doesn't treat thought disorder. Alrighty, thought thinking may be a little clearer. The person may be a little logical, but again, it may be more of an indirect effect due to the stability and affect, and as mentioned before. Let's see. The odor, the phenothiazines and haldol have one of the negative side effects is that it includes dry mouth, decrease in libido, and a huge one is sedation. Yeah. Another one is tardive dyskinesia, which doctors who prescribe these odor medications have to look out for. And what TD or tardive dyskinesia is, it's a horrible side effect. It's the involuntary production of facial tics, yeah, from having had taken any of these medications. Alrighty. So that's one thing you want to really avoid. And the tics can be very, very kind of dramatic. Yeah. Where, I remember as a kid, there was this a person who clearly had tardive dyskinesia. And what they would do when they would walk around, they were constantly doing it, rolling their tongue. They just couldn't control it, and they just looked really bizarre. But that person would walk with their spouse, and the spouse seemed to be fine. But it was clearly someone who was suffering from tardive dyskinesia, and that's a negative side effect you really want to avoid. Let's see. With the atypical antipsychotics, you have fewer of the negative side effects. Okay, but for some of these, like clozapine, risperidone, you got to look. Physicians have another thing to look out for: a concern with the decrease in white blood cell production. Okay. Why would someone use the phenothiazines? It's kind of like the antidepressants. Some of the later generation antidepressants don't work on individuals, and it's the older stuff that does, for whatever combination of reasons. Psychological treatments can usually involve things such as cognitive rehabilitation, so helping patients work on developing, maintaining, or finding other ways to offset problems with their attention, memory, and organization and planning. Yeah, social skills training, right, so that they can increase their social networks, date, and so on. Alrighty, getting at helping people modify their beliefs, their expectations about making friends and dating and getting along with family members. This might involve role playing, social problem solving, and so on. Yeah, and also it can also just involve the kinds of things that goes on in other types of individual psychotherapy. Yeah, like getting at underlying causes of depression and so on. Family treatment may also be involved in terms of having family members or a spouse help the patient manage their symptoms. And with that, as I said before, I'm going to leave the description of brief psychotic disorder, schizophreniform, delusional, and schizoaffective to your reading in the text and a review of the PowerPoint. But with that, that's all I have to say about schizophrenia. And with that, thank you again for the privilege of your attention. And I'll see you on the next topic. Take care. Bye-bye.